Hi, everyone. This is Jen Perry. I'm president of the Li-Fraumeni Syndrome Association. And first of all, welcome, everybody. So excited to have you for our very first Ask a GC webinar series. And we're so excited to be able to do this with all of you and going into the future. So I think the first thing we just want to start with is, first of all, welcome to our presenters. And we have 3 presenters today who are really excited to help everybody out today. So we have Carly Grant, who is from Mass General in Boston. We have Jacqueline Shenda, and she is from Dana-Farber in Boston as well. And then we have Lamia Al-Soubey, and she is from the King Abdulaziz Medical Center in Saudi Arabia. And they're going to be covering a wide range of topics today. And in particular, many of you asked questions prior to the webinar starting. So we have some answers to some of those questions for you today. So before we begin and I turn it over to these 3 wonderful ladies, which I'm very grateful for, I just wanted to give you just a little bit of background, and they're going to get into a little bit more depth with you, but let you know how this started. And this was really a journey that started about 1.5 years ago. So Kathy Schneider from the Dana-Farber Cancer Institute and myself and Holly Fraumeni, we kind of put our heads together about really forming a group. You know, we have a lot of doctors and we have a medical advisory board, but there seemed to be a piece missing. And a real critical piece to us was the genetic counseling piece. So we had the physical side, but then there's the whole psychological and social side of it, which we feel is really important for comprehensive help and being able to serve our community, and that's all of you. And it is such an honor to have this group of men and women together here. And I will tell you, it's only growing. We have well over 20, and we are within countries all around the world. So they're going to give you some more details about it and some of the projects that they're working on. But please just know that this group is at your service, 365 days a year through our website, and they'll walk you through that. So again, other than just today, and as we have these series, if you ever need any questions answered or concerns, and we'll do the best that we can to make that happen for you, just know that we're a key click away for you. So with that, I'm going to turn it over to Carly.
And so we're representing the Genetic Counseling Advisory Group, which is a group of us who have a special interest in not only cancer, but specifically Li-Fraumeni Syndrome. Hopefully, we feel understanding some of the complexities of the challenges that are faced in this particular community. And so we're really excited to work together on several projects. Next slide, please. So there's about 25 of us in the Li-Fraumeni Syndrome Advisory Group from all over the world, including Japan and Saudi Arabia. And of course, we have Lamia with us today in Saudi Arabia. And some of the projects that we're working on include books and booklets, brochures, newsletters, directories, patient resources, a variety of different patient resources, planning conferences for different age groups, different concerns within Li-Fraumeni Syndrome, and of course the big conference that was wonderful in April, which was in Toronto. Many of us participated in that, and we meet monthly. We have, because we're all from all over the place, we have telephone meetings and we review all the various projects and the progress that we're making, and we often come up with new ideas, so we're definitely excited to be a part of this. Next slide, please. So in case you don't already know, and some of you are genetic counselors, so you definitely know this, but for other people, if you don't know too much about what we do, genetic counselors are medical professionals who have specialized education in genetics and counseling. And in general, what we do is we help to interpret the meaning of genetic testing results. We also provide supportive counseling. We serve as patient advocates. Of course, one thing that's not on here is we always obtain a detailed family history, which is such an important part of what we do in discussing things like risk and genetic testing options. And there's more than 7,000 of us worldwide now. Next slide, please. And we work in a lot of different areas, becoming more and more subspecialized as time goes on, but cancer genetics is definitely a big one, making up about a third. Some people work in prenatal or pediatrics, and also people work for industry, they work in research, and we work in a variety of different settings, but I would say the majority of us work for hospitals or in healthcare settings. So next slide, please. So if you don't already have a genetic counselor, we would highly recommend that you find one, because your genetic counselor can really be such an important point person for you, not only to help you and your family members get tested, get the follow-up and care that you need, and answer questions, but just to kind of be a point person if there's any need for maybe helping with referrals to medical specialists, and really almost anything. We can kind of be your quarterback. So there's a resource on there for how to find a genetic counselor if you don't already have one. Next slide, please.
So I want to reiterate Jen's earlier comments. Thank you, everybody, for submitting the questions ahead of time, because that really helped us shape today's webinar and talk. And so we're going to be doing our best to address all of the questions that were submitted. And Carly just reminded me that I have not introduced myself. This is Jackie, another genetic counselor at Dana-Farber. So we are going to do our best to address the questions that were submitted earlier throughout our discussion. But please type in additional questions that you might have as we're talking if questions arise and come up, and we'll also address those. And even though we do appreciate all of the questions that were submitted and we are trying to answer them as best as we can, there are some, unfortunately, that we're going to be unable to fully address because they are really specific medical questions for a specific patient question that is really above and beyond our purview as genetic counselors and more towards physician questions. But we would encourage you to contact your local genetic counselor or local physicians to follow up with those questions. And if we don't answer a question that you had wished we did, or we missed your question, please feel free to send in additional email questions and comments, and then we can hopefully try to address those as well afterwards. Next slide, please. I'm going to now pass it on to Lamia in Saudi Arabia.
Hello, everyone. This is Lamia from Saudi Arabia. I want to thank you for joining us tonight. So going to the basics, Li-Fraumeni Syndrome is a hereditary syndrome, genetic condition that is most commonly caused by a mutation or alteration in a gene called P53. The mutation takes away the gene's ability to function correctly. Approximately 70% of all families with Li-Fraumeni syndrome will have this mutation in the P53 gene. Mutations in the P53 gene predispose individuals to multiple tumors, including soft tissue and bone sarcomas, breast cancer, brain tumors, adrenocortical carcinoma, and acute leukemia. For individuals with an identified P53 mutation, the risk of developing any invasive cancer is approximately 50% by the age of 30 and almost 90% by the age of 60. Screening, including breast MRI and/or a mammogram, whole body MRI, colonoscopy, annual dermatology exam, and also we encourage discussion about prophylactic surgery with the physician, with your oncologist or genetic counselor. The next step after receiving Li-Fraumeni syndrome diagnosis is to find a healthcare provider and genetic counselor to start screening. We understand that this may be challenging to find an expert in Li-Fraumeni in some areas, but we are here in Li-Fraumeni Association tries our best to reach and educate healthcare providers everywhere. Since the discovery of P53 gene, our knowledge about P53 gene pathways increased. So researchers now are targeting those pathways to develop compounds for cancer treatment and prevention. In addition, management guidelines have been issued regarding screening and being updated frequently. There are hundreds and hundreds of described mutations that have been linked to Li-Fraumeni syndrome in P53 gene. Some mutations types seem to have lower risk than others. Data is still emerging, but we still don't have a clear phenotype-genotype correlation. And also, there is no different management guidelines based on different mutation at this time. I know some of you asked about this specifically. So all the guidelines that we have is really general guidelines for Li-Fraumeni syndrome diagnosis. I produce detailed picture of it may be used to help diagnosis or monitor treatment for a variety of conditions, including Li-Fraumeni. In terms of who to contact to offer whole body MRI, I guess Jen,
I am here.
She can comment on Li-Fraumeni syndrome or whole body MRI task force.
So just to let everybody know,
Hello, Jen, are you still here? So we'll continue answering the question until Jen is back. I know some of you asked if the airport security pose a radiation exposure threat. I only found one study that published in 2011 by Department of Public Health in California. The University of California concluded that there is no significant threat of radiation from airport scan. However, we understand that the estimation of cancer risk associated with the airport scan is difficult. By using the only available models of risk assessment, the risk would be extremely small, even among frequent flyers. This is what the study concluded.
Over the last several years, we have heard loud and clear that this has been probably one of the biggest issues within our community, both where can we get our whole body MRIs, insurance covering whole body MRIs, and we actually put a task force together just recently, and I want everybody to know that we've heard you and we're working very hard on it. Dr. Judy Garber, who's part of our medical advisory board, has agreed to help us with this, and we also have some very other key people around the country helping us. And I will let you know, you should hear some things pretty soon regarding what we're finding with that, but it's a very complicated thing to deal with, but we're finally, I think, making some headway, and we'll be able to make some announcements, I'm hoping, in the next several months. Also, we are working on a project to get to you which centers around the country will also have and be able to do whole body MRIs, as not every center has that capability. So we'll have that availability on the website very shortly as well. So thank you, Lamia.
Thank you, Jen. Now I'll pass the slide to Jackie.
Everyone, I am back. Again, this is Jackie from Dana-Farber talking. So we received a number of questions that talked about the family and asked about different cancer risks or risk to test positive in different family members. So we thought we would spend a little bit of time talking about that. Next slide, please. So one of the first questions that a lot of people have when they're first diagnosed with Li-Fraumeni syndrome is, could anybody else in my family have this, or could I be the first person in my family with LFS? And the answer is yes to both. The chances that a person is the first person in the family is estimated to be up to about 20%, and that we call de novo. So if a person is the first person in the family with a P53 mutation, they are considered to have a de novo mutation. And recent studies, again, have shown that potentially up to 20% of individuals have Li-Fraumeni syndrome due to a new mutation. So that means that it was not inherited from a parent, but a person who does have a gene mutation can pass it on to their children. So as Lamia was saying, P53 mutations in one copy of the P53 gene is what causes Li-Fraumeni syndrome. And so if you have 2 copies of the P53 gene, you're only going to be passing on 1 copy to your child. And the chances of passing on that gene mutation or that working copy of the gene are completely random. So it would be a 50% chance of passing that gene mutation on to your child if you yourself have the P53 mutation. But if you're the first person in the family with that gene mutation, then there is a chance that your parents could have the gene mutation or your brothers or sisters, but it's not 100%. Again, because it could be, if your parent has the gene mutation, then your brothers and sisters would have a 50% risk. But if your parent does not have the gene mutation, then there still could be a risk to your brothers and sisters. And that kind of leads us to the other question. The next question is, if my daughter is the first person in the family with LFS, so she's the de novo, her parents tested negative, what are the chances that my other children will have LFS? So we really wish we could say the chances if you test negative and your partner tests negative would be 0 to have another child with LFS. But we do estimate that it could be up to 1 to 2% to have a second child with LFS. And that's because there's the potential that multiple sperm or multiple eggs could carry that gene mutation, but it's just not in your blood. That concept called gonadal mosaicism. And so we do recommend testing the brothers and sisters of anyone who tests positive, even if the parents test negative. And that's because of that very small possibility of gonadal mosaicism. And that also leads me to the next question of who should have testing in my family. So if you have identified a person in the family to have that P53 mutation, we first recommend testing the parents and the brothers and sisters. And then depending upon if a parent tests positive or negative, then you could then expand out and make recommendations for testing aunts, uncles, cousins, grandparents, kind of following that mutation through the family, which side of the family it's coming from. But sometimes we recognize that we're not able to test our parents if they've passed away or if they're unavailable for testing for various reasons. So then we would recommend sharing this news with extended family members on potentially both sides of the family so that anybody at risk with that gene mutation could have that counseling and testing if they wish. Many people have also asked about, I have a gene mutation, should my children have testing? When should they have testing? So if you do have a gene mutation, there's that 50% chance to pass it on. And the question of the timing of testing children is really nuanced and complicated, and I think has really changed in the past few years. Typically, we think about testing children for a cancer gene predisposition like Li-Fraumeni Syndrome if there is medical management available for the child. And so in the last couple of years, there have been some published guideline screening management recommendations that have recommended some screening tests in children. And so we are now recommending testing in children, but really having a nuanced conversation with parents about the pros and cons of learning that information in infancy and childhood. And really, is that something that you want to know at this time? And would you want to move forward with the screening guidelines and screening options that are available? So it's not, you know, an absolute. It's a definitely a nuanced conversation. And I haven't seen any questions come through in the chat. So as you're listening to us, please, if there are any other questions that come through, please submit them. So I think with that, I'm all set with, if no other questions have come through, I will pass it now to Carly with the next slide, please.
So I wanted to just address some of the, I guess, common concerns that we often see in our patients and families with Li-Fraumeni syndrome. And before I get to some of those topics, I wanted to address specifically some of the questions that came in that fall into this category. One question or one concern people often have is about insurance and whether it will cover the cost of testing and just generally the cost of genetic testing. So sometimes people don't have great insurance, or there's financial concerns. Luckily, the cost of genetic testing has come down quite a lot over the years in general. There's a lot of competition among genetic testing labs to get everyone's business, and insurance companies also seem to be a lot better about covering testing. Now, when it comes to doing what we call single-site testing, which is if you already know there's a P53 mutation in a family, and so you're testing another family member for that mutation, that's actually relatively inexpensive in general. Generally costs a couple $100. There may be a little variety in that or variation in that cost between labs, but even in cases where somebody doesn't have good insurance, there are often ways that it can get paid for. They can often work with the lab to set up some sort of payment plan, or perhaps family members can chip in a little bit here and there to get that type of testing done. Again, if you know what mutation you're looking for, it should really not be more than just a few $100s for that. So hopefully that's helpful. Somebody did ask a question about their child being born with what looked like a de novo P53 mutation. Jackie did address the fact that that seems to happen in about 20% of people that have Li-Fraumeni syndrome, meaning that it was new mutation, neither parent has that mutation. And of course, we just don't know why this happens really. It happens very, very early in the development of the fetus or the embryo. And I don't think anyone really knows. Things just come up sometimes and we don't have any control over them. So bad luck, I think that's a term that a lot of people use to describe getting cancer or having these cancer syndromes. And that's certainly one way to look at this. It's very challenging. You know, nobody really knows what that feels like if you're not in that particular situation. So it's always important to get as much support as you can. But we're, always sorry when we hear about these situations and those types of things. So if you have more specific questions about that particular topic, let me know. And then another issue that's been coming up, which I unfortunately don't have a real straightforward answer to, so if Jackie or Lamia does, feel free to chime in. We're doing a lot more genetic testing nowadays. We do these multi-gene panels where you can be tested for many genes all at the same time. So a lot of people are getting tested for P53, even if there is a high level of concern for it. With that, we're starting to see a lot more mutations come up. And we're starting to learn that some of the mutations may not be as harmful as others. And so the other thing that happens sometimes is people learn that they have a P53 mutation, and then they find out at a later point that the laboratory sends an update on the meaning of that particular mutation, and they may reclassify it to something called a variant of uncertain significance. And somebody did ask a question to that. And that basically means that, okay, we first thought that this particular genetic change was a full mutation. It was a harmful change that makes it so that that gene can no longer do its job, which is to help prevent cancer. And so that would be a full mutation causing all of these high cancer risks that we see in Li-Fraumeni syndrome. If it gets reclassified, if we learn more about these particular changes and it turns out maybe it's not totally clear how that alteration affects the gene, sometimes they might put it in that category of no man's land, which is a variant of uncertain significance. These reclassifications don't happen too often, but we are seeing them happen more and more now that we're learning more and more about this gene and different mutations. It's hard to think about how to justify getting all of the intensive Li-Fraumeni Syndrome screening in patients or families where what we once thought was a mutation is now maybe thought to be in no man's land, or maybe it's thought to be something that isn't as strong of a mutation as we thought. I don't have a clear answer for that, except I think, as Jen said before, just in terms of advocating for the highest risk patients and families to get what we feel is necessary in terms of whole body MRIs and such. We're trying to make access to that better and better and easier, but I don't have a straight answer to that particular question. I don't know if Jackie has anything to say.
No, I think that's it. I think you summed it up really well. And another aspect of the reclassification piece is some of these changes. There's different types of mutations we're learning within the P53 gene. So some are called partial deficiency alleles, which basically means that the P53 protein is working, but maybe not at 100%. Maybe it's only working at 20% or 30%. And so they're calling it, now they're changing that classification to not a real mutation, but a variant of uncertain significance, because they're not quite sure exactly what those cancer risks are going to be associated with a partial functioning protein. And part of the reason for the reclassification is, and the question just came in asking if this is happening more often. And I think about a year or two ago, we got an influx of these reclassifications. And part of that is because the American College of Medical Genetics, ACMG, had put out guidelines on how to classify different variants within a gene. And so historically, all the labs, each lab doing genetic testing would come up with their own criteria on what they would call a pathogenic mutation in a gene and what they would call a variant of uncertain significance. And we were finding that different labs would classify the same exact change in the gene differently. And so a group of scientists and geneticists got together and really worked hard on creating some standard guidelines on how laboratories should be interpreting genetic test results. And so when that happened, some of the laboratories went back to how they had previously classified P53 variants and then reclassified them based on the new criteria. So it wasn't necessarily that we learned more about that particular variant. It was just that it is now put into a different bin of classification. So a lot of these partial deficiency alleles fell into that category where they previously were considered mutations and now they're considered variants of uncertain significance. But not too much about our understanding of that particular variant had changed. So that adds a little bit more. And then as I'm talking, I'm also thinking about how this might loop back to what one of the earlier questions that Lamia addressed was, what are the cancer risks associated with having a P53 mutation? So historically, a lot of the research done on the cancer risks were really done on the families that have the classic presentation of multiple family members with cancer at very early ages in a clear pattern. And what we're learning with our broad panels, and it definitely has changed over the past 5 years or so, where P53 is now routinely done for individuals who have different types of cancers, not just the core LFS cancers. We're learning that those overall cancer risks are probably a lot lower than the historical numbers, because not only because we're learning more about these classic mutations, but also because there's more of these non-classic partial deficiency alleles being detected. And so if we historically have thought of the risk of a first cancer being very high, the second cancer maybe about 50%, 40, 50, 60%, you might read, as we're testing more people, we're finding more families with individuals who have the gene mutation but have never had cancer. And so we think that as the research continues in this area, our understanding of these cancer risks are going to evolve, and maybe we will be able to tell you which families have the higher the higher risk than which might have the lower risk. Yes, go ahead.
Gene panels are well established in probably countries in North America, like US and Canada, but in other countries globally, gene panels are not included all genes. So if you get tested outside the North American content, you probably need to check the gene panel, the genes included in gene panel, and make sure that the P53 is included before just concluding that the result is negative while your gene is not included, or the gene that is suspected or under question is not included. Because I know where I'm coming from, not all panels that we send for has B53 on it. So we have to check it before we make sure.
That's a great point. Yeah, thank you for clarifying that. Very important to know. We sometimes get, Jackie and I sometimes forget that this is going on all over the world and lots of oh, it looks like there's another question coming in. Let's see. So I'm gonna, I'll say the question out loud. Can everyone see this question?
Yeah, I think everybody can see the questions. Is that correct, Jen?
I think so, but there could be some people just on the phone.
Oh, okay. So the question is, so what does a VUS, a variant of uncertain significance person, do about screening going forward? I understand the 30% false positive risk of screenings. Yep. But what about the missed test and possible diagnosis? I think the question is asking that what kind of risk do you run if you're not getting the screening of developing cancer if your genetic change is now classified to a variant of uncertain significance?
So I can address the first part, and maybe Claire can comment on the second, and Livia as well. But I apologize if I was confusing with my previous discussion about the VUS. So I think there's multiple layers here. One is that a person has a concerning variant in the P53 gene that was previously considered a pathogenic variant and now is considered a variant of uncertain significance. And then also a person who might just have a variant of uncertain significance in general. So I think it might be important to just talk about variants of uncertain significance in general. In the general sense, a variant of uncertain significance, or VUS, is a change in the P53 gene, but the laboratory and the scientists cannot classify it as either a clear benign normal variation or a classic mutation that does increase risk for cancer. So in general, with cancer predisposition genes, when we get a variant of uncertain significance, we're not standardly recommending cancer screening for that syndrome only simply based on a variant of uncertain significance, because we know there are some research studies that show about 90–95% of those variants of uncertain significance are later reclassified as normal variation. So we don't want to be putting people through that high level of management and labeling them with Li-Fraumeni syndrome if they probably won't be. But the caveat to that is when we do see a variant of uncertain significance that does show some of those concerning features of reduced partial deficiency or was maybe previously pathogenic and now a VUS, we look at why that classification has changed. So in some circumstances, there really is clear evidence to show that maybe this is not a concerning variant, in which case we may not recommend screening. But I also want to preface this as this is our approach at Dana-Farber. So different institutes and different places may approach these differently, but we spend a lot of time looking at the particular P53 variant that comes in and looking at our our knowledge of the gene and the variant, and then how that lab has classified it. So every case is very nuanced, and so I don't want to leave any of you with the misimpression that all pathogenic to VUSs should still be followed like Li-Fraumeni, because really, when we look at them, many of them shouldn't be. So it's really on a case-by-case basis.
And I would echo what Jackie said. I mean, I'm in a different institution, but I think we take a very similar approach, and it almost like a holistic approach to these, in the sense that not only are you taking a close look at, why did the reclassification happen, on what basis, what do other labs call it, and on what basis, but you also want to look at the general clinical picture of the person and the family. In any of these cases, if it's a family that looks very suspicious for Li-Fraumeni syndrome, you're obviously going to be much more likely to err on the side of caution with regard to the kinds of screening that you're recommending versus, a family or a person where there's really nothing that is there. So it is nuanced. I agree. I think all of us kind of do things in a similar way, and you really do have to look at every piece of information in front of you. Each situation is a little bit unique. So hopefully that's helpful.
We don't recommend the Li-Fraumeni syndrome guidelines for testing, but we also go back to the family history that brought the index or the patient to the clinic in the first place. So we will recommend the testing or the annual testing based on the family history only, but not the variant of uncertain significance that have been detected in the testing. This is what you're doing, guys?
Yeah, absolutely. I think the family history plays a really important role. And then when we do have patients that are in that position of having a VUS, but there is concerning features of that VUS, our physicians really spend a lot of time talking about the pros and cons of screening and management. Like the person who typed in mentioned that there's a huge 30% false positive risk of screening, meaning that you can detect incidental findings on whole body MRI that may not actually be cancer, but lead to other invasive procedures or other additional screening. And that's a real potential downside of screening. And so our physicians spend a lot of time talking about the pros and cons and coming up with a joint decision about whether or not to do screening in the case of a VUS. And so it's definitely very complex and not just a straightforward answer for everybody.
And I would add too that this is the same approach we really take for any cancer syndrome, in that although there are particular guidelines in place for many of the classic cancer syndromes, there's always the caveat when you have someone, for example, who tests positive, that the medical management that may be recommended to them may not be exactly what the guidelines are, and it may be, they're often sort of individualized based on someone's personal family history. So that's kind of that holistic or multi-pronged approach to medical recommendations is always nuanced. Hopefully that answers your question to some degree. And so, I think we've covered a lot today. I would just like to add that I have an appreciation, and I think all of us genetic counselors have a real appreciation for all of the things that the Li-Fraumeni syndrome community has to cope with that really are uniquely challenging. I think unique compared to even some of the other classic cancer syndromes. There's a lot of uncertainty on a lot of different levels that have to deal with every day. In some cases, grief and questions about screening and prevention, how to get it covered, what the latest recommendations are, just how to communicate with family members, children, All of these things, I think, are even harder, more challenging in some ways for those with Li-Fraumeni syndrome compared to even people with other cancers, with some other cancer syndromes. So we have a real appreciation for that and recognize those challenges. So if you have any questions about any of those topics too, we'll do our best to address them. So I don't know if we want to leave a little more time for questions, or if we want to close things out from here. I will say that moving forward, I think the hope is that we'll do more webinars where there'll be perhaps us, perhaps other genetic counselors, but looking maybe more topic-based, depending on what your interests are and what we've covered today. Perhaps in the springtime, maybe March or April. So stay tuned for that. So we're thinking April-ish. We'll look forward to it.
Yeah, with that said, please share with your friends, your family, the community members that you know out there. If you are, let them know if there's any topics they would like to see at one of our future webinars with Ask a GC, just to please email it into us or give us a call on the info line, however you want to do it. But it certainly helps all our genetic counselors to be as prepared as they can for you and for the topics that really interest you that they can help you with. And I think that's it, unless, again, if anyone thinks of questions when they get off the phone on this webinar and they're like, oh, I wish I had asked that, you can certainly still write in, ask us, and we'll make sure we get those questions to these three awesome counselors here. So we'll make sure that we can try to get as many other questions answered as possible. Ladies, is there anything else?
No, I just wanted to thank everybody for their interest and their questions.
Yeah, thank you so much. This was a lot of fun.
Thank you to the three of you also for your time. This was wonderful.
Thank you. Thank you, Jen. Thank you, everybody for attending.
All right. Thank you, everyone. And we're looking forward to the next one. Take care.